This is the second part of our pathophysiology discussion of alterations in the cardiac system. And we're going to talk about the disorders of the heart wall. First, we're going to think about pericardial disease and understand that this is localized manifestations of other disorders, such as an infection or maybe trauma, surgery, neoplasm. It could be a metabolic change, immunologic, or vascular disorder that causes the disease of the heart wall. Inflammation of the pericardium is called pericarditis, and this can result from innumerable sources like infection, drugs, or tumors. And pericarditis presents with symptoms that are physically troublesome for a patient, but by itself, they aren't life-threatening. However, coupled with other processes going on, it could be very detrimental to their health. We can also see fluid collecting in the pericardial sac. This is called pericardial effusion. Our cardiac function can also be very severely impaired if there's too much fluid around our heart. And this volume of fluid, when it accumulates rapidly, could lead to further damage to the heart, and actually potentially could cause our heart not to be able to pump the way it should. Constrictive pericarditis happens when now we have scarring and calcification as well. Acute pericarditis is often idiopathic, but can also be due from trauma, neoplasm surgery, radiation therapy, even uremia and bacterial infections like TB. You will note on physical exam that there's a friction rub at the apex at the left sternal border, accompanied by low-grade fever, sinus tachycardia, hypotension, and you might even pick up a difference in systolic blood pressure of 10 millimeters of mercury or more. And when there's this decrease in systolic blood pressure, we call this pulsus paradoxus. And this happens with inspiration. You can see the shaggy fibers on this picture and the roughened area of the pericardial sac or membrane, and that's what's causing this friction rub. And the symptoms that are notable are several days of fever. Usually it's benign with a sudden onset of severe retrosternal chest pain that worsens with respiratory movement over time, especially when you're in a recumbent position. This pain can also radiate to the back, and this is because it's irritating the phrenic nerve, which innervates our trapezius muscle. And so you'll often have patients complaining about back pain. Now, patients with acute pericarditis will also say that they have dysphagia, difficulty swallowing, restlessness, irritability, anxiety, weakness, and also malaise. And this friction rub that you hear, it's a very scratchy, grating sound when you're listening under your stethoscope. The friction rub not only can be present, but sometimes you don't hear anything at all, and you might just hear it come and go as well. You might want to get inflammation markers like CRP, which should be elevated because there's an inflammatory process that's occurring in the body. You also will see some ST segment elevation without Q waves and PR segment depressions on an EKG. Your provider might ask you to help your patient and to get them ready for ultrasound, CT, or MRI as well. Those are other diagnostic modalities that we use for acute pericarditis. It's not diagnosed though unless there's two of the following four criteria. Chest pain, that's characteristic of pericarditis, which I described to you, pericardial friction rub, or you see the EKG changes that we discussed earlier, or there's new or worsening pericardial effusion as well. You'll learn more in MedSurg how you treat it, but with uncomplicated acute pericarditis, we do use anti-inflammatory medications like NSAIDs and colchicine, which we, just as a side note, we use colchicine when people have gout flare-ups as well as NSAIDs. And so we would be checking the CRP in the blood to help determine if our treatment is working or not, and if that elevation has come down. We will evaluate the pain by asking if the analgesic is working or if they require more extensive pain remedy. If there's extensive fluid, you may need to set your patient up for aspiration of this excessive fluid. That might be necessary as well. In severe cases of acute pericarditis, it could lead to tamponade if there's too much fluid and we don't release it. Tamponade, by definition, is the accumulation of fluid in the pericardial cavity that's formed with pericarditis, and it's when there's approximately 50 mLs when there's more. Okay, so tamponade is life-threatening. There's cardiac compression with increased venous pressure, leads to heart failure if that pressure exceeds the diastolic blood pressure. Now, when pericardial effusion is occurring in our patient, it can create sufficient pressure to cause such a compression that it's causing the pericardium not to be able to stretch and accommodate the way it needs to. And these large quantities of fluid can't be released. And this fluid is accumulating so rapidly, but there's nowhere for it to go. So even just, like I said, that small amount of 50 mLs can cause serious conditions known as this tamponade. With individuals with cardiac tamponade, they usually will say they also have dyspnea, tachycardia. You'll see JVD or jugular vein distension, cardiomegaly, and pulsus peridoxis, which we have already discussed. Other things that you might ask is for chest x-ray, because you can see this configuration that looks like a water bottle that is outlining their cardiac area, or it's forming this cardiac silhouette. It looks like a water bottle. And when you listen, it may sound very distant or muffled, these heart sounds. It's hard sometimes to appreciate the apical pulse. Your patient will have a dyspnea on exertion and dull chest pain as well. When you get an echocardiogram, it's sensitive enough to detect effusions of fluid as small as 20 mLs, and it really is considered the most accurate and reliable method of diagnosing pericardial effusion with tamponade. You can also get CT or an MRI also. If the fluid isn't released from the cardial or precardial sac, or pericardial sac, your heart can actually go into obstructive shock. So again, it's not just about moving the fluid, but what it's going to do to, overall to the rest of your body if your heart is in shock. And whatever is causing this underlying tamponade, you need to go and fix that first, or address that first. Recurrent pericardial effusions may require surgical creations of a window, which will allow the drainage of fluid and prevents tamponade from happening. Constrictive pericarditis, sometimes called restrictive pericarditis or chronic pericarditis, many different terms for it. It can be caused by TB. It can be autoimmune or idiopathic. Maybe it was a viral infection, radiation, surgery, neoplasms, or collagen vascular disorders like lupus. and rheumatoid arthritis, which we talked about, and it compresses the heart and reduces the cardiac output. Additionally, we have fibrous scarring that occurs and calcification. This can lead to parietal and visceral layers to now adhere to itself. So not only is the pericardium area inflamed, it's thick, and it's going to cause a restriction of the heart to pump effectively. Now, because this constriction is gradual, the clinical manifestations develop pretty slowly as well. And so the first things you might hear about are exercise intolerance, dyspnea on exertion, fatigue, and even loss of appetite or anorexia. 2/3 of our patients that present with pericardial effusion also have heart failure as well. A 23-year-old patient recovering from recent viral infection presents with severe chest pain that worsens with respiratory movement when lying down. They have a low-grade temp, heart rate of 100 beats a minute. What's the most appropriate intervention? So if you see this type of question, first you have to recognize that we are referring to pericardial effusion. And because they're in severe chest pain due to pericardial effusion, the first thing we would do was administer analgesics. So the answer here is A. Cardiomyopathies, these are a group of diseases that affect the myocardium, and they're pretty diverse, but most of them are going to result in remodeling that's caused by the effect of the neurohumoral responses to ischemic heart disease or responses to hypertension on the heart muscle. We also have cardiomyopathies that are secondary to inherited disorders or infectious diseases, if you were exposed to toxins, or the systematic connective tissue diseases like lupus and rheumatoid arthritis. Also, we can have cardiomyopathies that are from nutritional deficiencies as well. But many of the cardiomyopathies are idiopathic, and they can be characterized as dilated, hypertrophic, restrictive, depending on their tissue characteristics, genomics, and the hypodynamic effects. And so we are going to look at the dilated, hypertrophic, and restrictive types of cardiomyopathy. Dilated cardiomyopathy, sometimes these are called congestive cardiomyopathies, and you see that these are more associated with heart disease, diabetes, renal failure, drug and alcohol toxicity, and a genetic component. You're going to have impaired systolic function that leads to an increase in cardiac volume. With so much volume, the ventricle starts to become dilated, leading to heart failure with low ejection fraction. So you're not able to get much of that cardiac volume out with every pump. We also have hypertrophic cardiomyopathy, and this is when there's going to be thickening of the myocardium. The valves and the septums become obstructed. This can cause ventricular dysrhythmias, and we know that ventricular dysrhythmias can lead to sudden death. Restrictive cardiomyopathies will restrict the filling and increase diastolic pressure of one ventricle, but also it can affect both ventricles. And this is with normal or near normal systolic function and wall thickness. What you'll see is right heart failure with systemic venous congestion, cardiomegaly, which is an increase in the heart size, and dysrhythmia. So overall, cardiomyopathies is a term that we use when we say that the heart itself, the heart muscle, is diseased. Now let's look at the different types of cardiomyopathy in relationship to the normal heart. Look at the size of the ventricles and the ventricular space and the cardiac muscle or the myocardium that surrounds the ventricle. And this will give you an idea of the difference in anatomy, what you would see with cardiomyopathies. And see with this dilated one, you see that there is a more globular shape, and you're going to have the largest circumference of the left ventricle between the apex and the base of the heart here. With the hypertrophic cardiomyopathy, you see that this left ventricular area is so thick that you can hardly pump anything out. We can't hardly hold anything as well. The left ventricular cavity is small. The left atrium is going to be dilated in result of this, and this is due to poor diastolic relaxation of the ventricles. Think of them being very uptight. With D, we have restrictive cardiomyopathy, and this, now you look and see the left ventricle is normal, but look at the left atrium, it's dilated, and this is because there's reduced diastolic compliance of this ventricle. The heart muscle can't expand or contract very easily in this type. Whether you have dilated, hypertrophic, or restrictive cardiomyopathy, this can all lead to a decrease in SV, CO, and can lead to CHF. SV is a decrease in systolic volume, CO is decrease in cardiac output, and CHF is congestive heart failure. And I did just want to show you some real examples of hypertrophic cardiomyopathy and dilated cardiomyopathy. These are pictures that are taken right out of your textbook. Hypertrophic obstructive cardiomyopathies. These are the most common inherited heart defects that are associated with left ventricular hypertrophy. And you can take a closer look in your book if you want with more description, but I did want you to see what it looked like on an actual heart. Disorders of the endocardium, which is the innermost lining of the heart wall, it can damage the heart valves, and the heart valves are made of endocardial tissue. This damage can be congenital or acquired. The acquired forms are due to inflammation, ischemia, trauma, degenerative, or infectious alterations of the valvular structures and the valvular function. Now, the structural alterations of the heart valves result from remodeling changes that occur within the valvular extracellular matrix, and this can lead to stenosis and regurgitation. Sometimes it can even lead to both. Now, there's 4 heart valves, but they may not all be affected, but they also can all be affected. The left heart, the mitral and the aortic valves, though, are going to be more commonly affected than the tricuspid or their pulmonic valves. And those are the valves that are on the right side of the heart. So you hear more about mitral regurgitation or stenosis, or aortic regurgitation or aortic stenosis over tricuspid and pulmonic stenosis or regurgitation. Now let's just talk about stenosis. This is when the valve, that orifice, is constricted and it's narrowed. So impeding that blood forward or having that increase in workload of the cardiac chamber proximal to the diseased valve is what defines stenosis and what makes this stenosis an issue. We can't move that blood forward. Intraventricular or atrial pressure increases then in the chamber because it's trying to overcome that resistance to push and flow that blood to the next area. So that valve is too tight. That increased pressure causes the myocardium also to work harder, which will then, if you work any muscle harder, it leads to myocardial hypertrophy or an enlargement of the heart muscle. But with the valvular regurgitation, we are going to have insufficiency or incompetence of the valve leaflets or those cusps. They're not able to shut completely. Well, if this area that was intended to be like the gatekeeper of flow just allows blood flow to come in and out without being closed when it's supposed to, then we're going to have leaking during systole or diastole. There's going to have blood leaking back into the chamber that's proximal to the incompetent valve. It's going to move backwards. And this produces a murmur or an auscultation that you can hear with your stethoscope when this happens. Regurgitation will increase the volume of blood to the heart that has to be pumped, and it increases that workload of the affected chamber. If you have increased workload, you guessed it, you're going to have increased muscle work leading to hypertrophy. Volume is going to be increased, leading to chamber dilation. Okay, so that's what's causing that hypertrophy. When you think of stenosis, think too tight. When you think of regurgitation, too loose. First, we're going to talk about stenosis. Aortic stenosis is the most common of the 4 types of valvular abnormalities. And the 4 types I'm talking about: aortic stenosis, mitral stenosis, aortic regurgitation, and mitral regurgitation. So stenosis of the aortic valve is the most common, and it affects about 5% of adults that are over the age of 75. And there's 3 common reasons. There's either the calcification or degeneration that happens related to aging. There's also the congenital bicuspid valve or inflammatory disease that's caused by rheumatic heart disease. The pathophysiology of aortic stenosis itself is complex, and there are some numerous gene abnormalities that have been implicated as well. But autoimmunity disorders in calcium transport, apoptosis of endocardial cells, and a decrease in nitric oxide synthesis have been also to blame. In aortic stenosis, the orifice of the aortic semilunar valve is narrowed, and because it's narrowed, it will cause diminished blood flow from the left ventricle into the aorta. This is called outflow obstruction, and it's going to increase the pressure when the left ventricle isn't able to push forward the blood into the aorta. It's trying to eject blood through the narrowed opening. The byproduct of this is going to be left ventricular hypertrophy because it's compensating for that increased workload. But eventually, hypertrophy will increase myocardial demand, and we know what happens when supply and demand are off. The coronary arteries won't be able to supply oxygen and blood to the demand that the heart needs, and this could lead to ischemia and angina, eventually dysrhythmias, and then myocardial infarction or heart failure. With aortic stenosis, it does tend to develop gradually, and the classic manifestations of aortic stenosis are going to be angina, syncope, and heart failure. You would also see a decrease in stroke volume, reduced systolic blood pressure, and narrowed pulse pressures as well. The heart rate of your patient will often be slow, and the pulses will often be faint. Now with mitral stenosis, this is also impairment of blood flow, but this is from the left atrium to the left ventricle. Mitral stenosis is the most common form of rheumatic heart disease. In this process, there's an autoimmune activation of lymphocytes and macrophages that lead to inflammatory damage. When there's inflammatory damage, you're going to have scarring, and the scarring is happening on the leaflets that are in this valve. This scarring is going to cause these leaflets to be very fibrous and fused, and it's going to cause it not to be compliant any longer. The chordae tendineae becomes very shortened. Now, when the blood flow can't move forward, this is going to result in incomplete emptying of that left atrium. And if you can't empty everything, that atrial pressure is going to start to elevate. because now the atrium is going to try to force blood through the stenotic valve. When you have continued increases in the left atrial volume and pressure, it can cause chamber dilation and hypertrophy. Eventually, it will back up even further and you will have pulmonary hypertension. So you want to be able to connect mitral stenosis and pulmonary hypertension. If you don't treat mitral stenosis and it becomes chronic, pulmonary hypertension and right ventricular heart failure are the complications of untreated chronic mitral stenosis. The risk of developing some type of atrial dysrhythmia is higher, so think about AFib specifically, and dysrhythmia-induced thrombosis is high as well. So you can cause a blood clot to form and shoot out or embolize from this fibrillation that can occur in the atrium. Now we're going to talk about regurgitation. An aortic regurgitation results when there's an inability of the aortic valve leaflets to close properly. It's like trying to close a door, but you leave it propped open a little, so then you're going to have a leak. And the hemodynamic repercussions depend on the size of this leak. Now, during systole, blood should be ejected from the left ventricle into the aorta. But during diastole, some of the ejected blood flows back into the left ventricle because there is this leaking valve. We're going to get volume overload eventually because it's going to receive blood from the left atrium and the aorta at the same time during diastole. And as this end diastolic volume increases in the left ventricle, the myocardial fibers will begin to stretch because it's trying to accommodate for this extra fluid. However, compensatory dilation, though it's permitting the left ventricle to increase its stroke volume and maintain cardiac output now, it's not going to be able to sustain it long term. And this is when you'll start to see a high risk for heart failure developing, because ventricular dilation and hypertrophy won't be able to compensate long term. We're going to have aortic incompetence and heart failure. With mitral valve regurgitation, it's pretty much the same process, but now we're talking about the mitral valve itself. And you're going to see deterioration of the connective tissue. We're talking about left arterial hypertrophy now, leading to compensatory dilation that tries to sustain the need and to compensate, but eventually will also lead to heart failure. Okay. Although we already reviewed aortic stenosis, I wanted you to be able to have these two processes very close together in the slide presentation so that you can review and note the differences between aortic stenosis and mitral valve prolapse syndrome, which will be the next slide. So most of this we already know. We know that it's a poor forward flow process. Decreased cardiac output is going to lead to decreased pulse pressure and the backup of blood behind the valve itself. So left ventricular hypertrophy leading to heart failure, that increase in oxygen demand. Remember that supply and demand is offset. There's a deficit, so it's going to lead to ischemia. Over time, your patients will experience MI and heart failure if it's untreated, and you can see the symptoms here. It's important to note that this is the most common valve abnormality. However, with mitral valve prolapse syndrome, this is the most common cardiac valve disease in the US. And in this syndrome, one or both of the cusps of the mitral valve into the left atrium during systole are prolapsed. So what this mean actually is that the valves are floppy, and there's going to be alterations in the connective tissue in that area in the mitral valve. Because mitral valve prolapse is often associated with other inherited connective tissue diseases like Ehlers-Danlos or Marfan syndrome, we also see it with osteogenesis imperfecta. We know that there's a genetic predisposition or environmental disruption of the valvular development that's occurring during the 5th and 6th weeks of gestation. And there could be also a relationship between mitral valve prolapse and hyperthyroidism as well. So, mitral valve prolapse is completely asymptomatic in some cases. When you go to auscultate heart sounds on routine exam, you might hear a regurgitant murmur or a mid-systolic click in an individual that otherwise is very healthy. The EKG or echocardiogram may demonstrate that there is no findings, and symptomatic mitral valve prolapse can actually cause palpitation related to dysrhythmias, anxiety, depression, panic disorders, and patients with atypical chest pain. So you can see here that there's a wide range of what your patient can be experiencing versus they're not experiencing anything at all. Many times the symptoms are very vague, they're puzzling, and we don't know what to attribute them to. They don't really require any restriction in activity or medical management, however. Occasionally, you will see this being treated with beta blockers because they're trying to alleviate that syncope, severe chest pain, or the palpitation type symptoms. If it's significant enough, then surgical repair may be necessary if mitral regurgitation starts to develop from mitral valve prolapse syndrome. Okay, so this is the most common cardiac valve disease in the US. So we talked a lot about ventricular hypertrophy. So what leads to this hypertrophy in the first place? So let's move now backwards and talk about what is going on in terms of how our cardiac system is reacting and our renal system is reacting. So if there is any type of myocardial dysfunction like infarction, ischemia, hypertension, or other types of cardiac disorders that lead to lower cardiac output, lower systemic blood pressure, we're also going to see simultaneous lower perfusion to the kidneys because our cardiovascular system feeds into the perfusion of the kidneys. Well, this cardiac output and systemic blood pressure decreases, our baroreceptors are going to be activated in the left ventricle, aortic arch, and carotid sinus. The medulla will then be stimulated, which is our vasomotor regulatory center, and the SNS becomes activated, the sympathetic nervous system. When our SNS becomes activated, we will have an increase in catecholamines, so our body will release epinephrine and norepinephrine, leading to vasoconstriction. At the same time, this lower output and lower pressure will trigger renin to set off the renin-angiotensin-aldosterone system, and this becomes activated as well. Well, it will release neurohormones like angiotensin 2, aldosterone, to help to compensate and bring up that blood pressure. It will eventually lead to the retention of sodium and water, vasopressin, cytokines, endothelin, to result in vasoconstriction. Well, now we have an increase in blood pressure and heart rate, increase in afterload. This is going to further promote ventricular remodeling to begin. When we have ventricular remodeling, there's going to be hypertrophy and dilation of the ventricles. And this overall, because it's so thickened, it will result in impaired contractility of our heart that contributes to heart failure. So which valve disorder is characterized by impaired blood flow from the left atrium to the left ventricle? So you might need to go back and review the anatomy, but it's indeed the mitral valve that is being affected here. With mitral stenosis, this is when your valve inhibits adequate blood flow from the left atrium to the left ventricle. Okay, so mitral stenosis is the answer. However, just so that you can compare, mitral regurgitation is permitting blood flow backwards from the ventricle to the left atrium. And of course, these aren't going to be atrial disorders because it's not on the right side of the anatomy. We're going to move on and talk about infective endocarditis. And this is just a general term that we use to describe some type of infection or inflammation of the endocardium layer, especially the cardiac valves. And the incidence in the US of ineffective endocarditis is actually increasing, and it's because we are now implanting surgically prosthetic valves. So the risk for infection has now increased. Bacteria that are most commonly caused or the cause of infective endocarditis are Staphylococcus aureus, which is the most common cause worldwide, but streptococci, enterococci, viruses, fungi, and parasites, rickettsia, these are all other potential bacteriums and agents that could cause infective endocarditis. So with infective endocarditis, there is going to be some type of adherence of a bloodborne organism to the damaged endocardium. It's going to form vegetations. Vegetations are a combination of fibrin and platelets aggregating into this area on the valve itself. What you will see as a result of this is regurgitation, murmurs, thrombi may form and they may embolize in these areas of vegetation. And actually, mitral and aortic valve vegetations embolize and cause stroke oftentimes. Let's look at here in a little bit more detail the pathophysiology of ineffective endocarditis. So we do know that there are risk factors that are associated with infective endocarditis, and this is having underlying valvular heart disease, or if you've had a valve replacement, if you are an intravenous drug user, or you've had a long-term indwelling catheter. And this can be for pressure monitoring, or it could be for hemodialysis, as well as a recent cardiac surgery. Okay, so anything that puts your body at risk for introducing a bloodborne pathogen that can move to the endocardium of the heart. Now, turbulent blood flow caused by these types of abnormalities like valvular heart disease, or if you have a prosthetic valve, they usually are going to affect the atrial surfaces of the AV valves, or the atrioventricular valves, or the ventricular surfaces of the semilunar valves. Endocardial damage exposes the endothelial basement membrane, and this is containing a type of collagen that attracts platelets to come. It's going to stimulate sterile thrombus formation on the membrane and cause inflammation. Then you have bloodborne microorganisms that can be introduced and adhere to the damaged endocardial surface. So these things are causing endocardial damage to the surface, but now we're introducing bacteremia into the system. Think about procedures like dental procedures, like the manipulation of gingiva, cardiac surgery, if you've had any type of genital urinary procedure or indwelling catheter, like we mentioned earlier. Maybe you've had a gastrointestinal procedure or surgery, or respiratory tract infection or skin infection as well. So if these things don't get mitigated or treated, and there's a potential for bacteremia at this juncture, we're going to have formation of ineffective endocardial vegetations, because here bacteria are going to infiltrate the sterile thrombi and accelerate fibrin formation. It's going to activate the clotting cascade. Now, these vegetative lesions can form anywhere on the endocardium, but usually it's going to occur around the heart valves and the surrounding structures of the heart valve. And although endocardial tissue is constantly bathed in antibody-containing blood and surrounded by monocytes and polymorphonuclear leukocytes that are scavenging around trying to clean up, bacterial colonies are inaccessible to host defenses because they're embedded in the protective fibrin clot. So it's really hard for our body's immune system to fight these types of bacterium. Embolization from these vegetations leads to abscesses and characteristic skin changes such as petechiae. You'll start to see Janway lesions, which are these non-painful hemorrhagic lesions that you can see on your patient's palms and the soles of their feet. Other things are splinter hemorrhages and ocellular nodes as well. So a patient is diagnosed with inflammation of endocardium due to Staphylococcus aureus, which is the most likely medical diagnosis. So hopefully you recognize that Staphylococcus aureus is the most often causative agent for bacteremia that leads to infective endocarditis. So many of the cardiovascular diseases that we've touched upon all lead to heart failure if not treated appropriately. So it's really important to understand, as well as the fact that over 5.7 million Americans over the age of 20 have heart failure, and it causes 1 in 9 deaths here in the United States. Ischemic heart disease and hypertension, though, are the most important predisposing risk factors. Did you know that of the individuals that have heart failure, 75% of the cases are with patients with hypertension? But there are other risk factors that are notable, like our age, smoking history, obesity, diabetes, renal failure, if there's any type of valvular heart disease, which we've talked about, the stenosis and the regurgitations of the valves, cardiomyopathies, myocarditis, congenital heart disease, and even patients that drink alcohol excessively are at increased risk for heart failure. But most causes of heart failure will result in dysfunction of the left ventricle, and we call this systolic or diastolic heart failure. The right ventricle also may be dysfunctional, especially in pulmonary diseases when we have right ventricular failure. And there's some conditions that cause inadequate perfusion despite having normal or elevated cardiac output, and we term this high output failure. So it's important to understand the different types of heart failures because the interventions are going to be quite different. Now with left heart failure, you're going to have a backup of flow, which will then lead to pulmonary congestion. So you're having complaints of shortness of breath. You will have cough, productive cough. You're going to see a systolic issue leading to this left heart failure. And oftentimes, if left heart failure isn't corrected, it's going to push back into the right side and cause right-sided heart failure. And this is when our right ventricle is unable to provide adequate blood flow to the pulmonary circulation. And when left heart failure is severe enough, the increase of left ventricular filling pressure is going to be reflected back into our pulmonary circulation. And when this pulmonary circulation pressure rises, we're going to have resistance moving to the right ventricular emptying, which will increase. Now, this right ventricle will start to hypertrophy because it's responding to that increased workload, right? So just like any other muscle in our body, if we work it out, it's going to grow. However, this growth will restrict the ventricle from contracting appropriately. It undergoes progressive diastolic and systolic deterioration. Eventually, it's going to dilate and fail. When this happens, the pressure will continue to rise in systemic venous circulation, and this is when you're going to see that JVD, or jugular vein distension. Okay, it's systemic venous circulation pressure. We'll also note peripheral edema and hepatosplenomegaly because it's all backing up. With high output failure, this is an inability for your heart to adequately supply the blood with blood-borne nutrients, despite having enough blood volume and having normal elevated myocardial contractility. In high output failure, your heart increases the output, but still your body doesn't have the metabolic needs that it's demanding. And the most common cause of high output failure is anemia, septicemia, hyperthyroidism, and any incidence of low thiamine. And this can happen when we have patients that are not meeting nutritional guidelines. In the US, this is called beriberi, which is thiamine deficiency, and it can be secondary to chronic alcoholism. Here you can see the pathophysiological highlights of left-sided versus right-sided heart failure side by side. We'll start with left-sided. With left-sided heart failure, you have ineffective left ventricular contractility leading to the inability for that left ventricle to pump. If the left ventricle isn't pumping well, then we're going to have decreased output to the body in the circulatory system. Well, if there isn't enough pumping action moving it towards the body, then blood is going to start to back up. And it backs up back into the left atrium and then back flows into the lungs. And this is why we have pulmonary congestion, dyspnea, and activity intolerance. This leads to pulmonary edema, and eventually it's going to lead to right-sided heart failure because it's backing up further. With right-sided heart failure, we have ineffective right ventricular contractility. And if our right ventricle can't pump, then we're going to have decreased cardiac output to the lungs. Blood will then back up into the right atrium and peripheral circulation. And this is why with right-sided heart failure, you're going to see weight gain, edema, and the livers, we might have hepatosplenomegaly, which means that the liver, the spleen may be enlarged, and we're going to see engorgement of the kidneys as well. When our cardiovascular system fails to perfuse tissues adequately, eventually this can lead to shock. And the impaired cellular metabolism that takes place will put our body in an anaerobic state. We're going to have a breakdown of the sodium potassium pump. We're going to have then sodium and water moving into our cells, which will decrease the volume in our vascular area. The pH is also going to be altered, leading to metabolic acidosis. In addition to impaired oxygen, we're also going to have impaired glucose. This impaired delivery or the use of glucose will eventually lead to our body trying to compensate at first. However, it will lead to muscle wasting. The toxic buildup of all the end products from muscle wasting will have reduced oxygenation and glucose, and this is a positive feedback loop that will continue. If we can't correct shock, then eventually it leads to organ failure and death, which is called MODS or multi-organ death syndrome. The manifestations are going to vary based on the different stages of shock, like hypotension, tachycardia, and an increased respiratory rate. Let's look a little bit more closely at this impaired cellular metabolism loop. And so if there is a decrease in tissue perfusion, again, we just saw that there's impaired oxygen and impaired glucose delivery, leading to further cellular metabolic damage. When we have impaired cellular metabolism, this puts us into a state of either impaired oxygen delivery and use or impaired glucose delivery and use. With impaired oxygen delivery, we're going to have a state of anaerobic metabolism occurring, which will increase protein metabolism at this time. We'll have a breakdown of lactic acid, decrease in our sodium potassium pump ATP. The intracellular sodium and water will start to increase as the fluid shifts out of the vascular space into the cells, which will then lead to decrease in circulatory volume. When we have an increase in protein metabolism as a result of anaerobic metabolism, then our proteins will also be decreased. This can further lead to what we call third spacing, and we're pushing or we're pulling back the vascular fluids into the cells because there's also increased capillary permeability. All of this will lead to cellular edema because we have too much fluid in our cells, but we're not going to have enough fluid in the circulatory system, so there's a decrease in circulatory volume. This will set off a clotting cascade, the inflammatory response, and cellular edema will then release lysosomal enzymes, leading to inadequate intracellular waste product removal. Okay? And this can lead to further tissue perfusion alterations. On the other hand, with impaired glucose delivery and use, as our serum glucose increases, we also will have catecholamines, cortisol, and growth hormone leading to increased lipolysis, increased gluconeogenesis, and increased glucogenolysis. With increased lipolysis, we're going to have an increase in our serum triglycerides and free fatty acids, which you will know on labs. With increased glycogenolysis, we're going to have a decrease in our body's energy stores. But what really is connecting back into the other pathway is this increase in gluconeogenesis, which will lead to a decrease in serum albumin and increase in serum branched chain amino acids. We're going to have, as a result, an increase in serum alanine, which also connects to increase in pyruvate, which the breakdown will be an increase in lactic acid. But here, due to this decrease in serum albumin, and also we'll have an increase in urea, nitrogen, what we'll see is more third spacing because we have a decrease in albumin. Okay, same thing as protein here. Now, this all can lead back to further impaired oxygen and glucose delivery. When we have an increase in cellular demand and consumption, but we have inadequate intracellular waste product removal, this feedback loop is going to continue, causing more breakdown of urea, nitrogen, and connecting back over to here the other side. So you're going to see these two things simultaneously happening. It is a positive feedback loop with the impaired glucose use. All of this leads to multi-organ damage and failure, and eventually death. What you're going to see oftentimes as compensatory mechanisms here is hypotension, tachycardic conditions, and an increase in the respiratory rate. There are 3 types of shock that we want you to understand in relationship to having cardiovascular disease leading to impaired cellular metabolism. And the most common of these types of shock are going to be the hypovolemic type shock. So remember in our last slide, because all the fluid is shifting back into the cells, we don't have a lot of fluid in the vascular space. Inadequate fluid volume in the vascular space will decrease your preload. It leads to decreased tissue perfusion, and it will increase your heart rate, your systolic ventricular resistance, and cardiac output. Whereas cardiogenic shock, which is the majority of the types of shock cases that you'll see when a patient has had acute myocardial infarction or heart attack, there's going to be dysfunction of the right or left ventricle where your heart can't pump enough blood to perfuse the body, and it has a very high mortality rate. And then septic shock has to do with systemic microorganisms that have been introduced. So we'll have bacteremia. Usually it's gram-negative bacteria that's worse than the gram-positives. And the most common cause of septic shock is through the bacteremia or the introduction of microorganisms into the respiratory system. And it results in a maldistribution of perfusion, leading to MODS, or multiple organ dysfunction syndrome. Eventually, we'll see systemic inflammatory response syndrome, which is SIRS, leading to severe sepsis, septic shock, and MODS. So that's the different pathways getting to MODS. So you do see that infection can lead to bacteremia, leading to systemic inflammatory response syndrome. We don't diagnose the patient with sepsis until they've met the two out of the four of the following criteria. They have a temp of 38 degrees Celsius or higher, or less than 36 degrees Celsius. If their heart rate is over 90 beats per minute, if their respiratory rate is 20 breaths per minute, or if their WBCs are over 12,000. Additionally, if you see WBCs that are under 4,000, or you see that immature white blood cells or an increase of bands are noted on your CBC with differential. Severe sepsis occurs when there's sepsis with organ failure. Septic shock occurs when now there's persistent hypotension despite giving your patient fluids. And MODS, or multi-organ disease syndrome, or death syndrome, is when there's homeostasis that can't be maintained without having persistent intervention. Now, there are two other additional types of shock worth noticing. The first one is anaphylactic shock, which we've already discussed when we went over that section of our pathophysiology book that went over hypersensitivity reactions. Anaphylactic shock, if you remember, is a type 1 reaction, and usually what you'll see is airway constriction, edema, third spacing, so the fluid moves into the cells and out of the vascular space, and it's going to result in impaired cellular metabolism. Neurogenic shock is the most uncommon type shock, and this primarily is due to spinal cord injuries, which will result in a loss of vasomotor tone, and hypertension and bradycardia will occur. You're going to learn more about neurogenic shock when you are introduced to the pathophysiology alterations of the neurosystem later next semester. So in general, it's helpful just to see what is occurring with the vital signs and what you're looking for at every type of shock. So the hypovolemic shock, cardiogenic shock, septic shock, anaphylactic shock, and neurogenic shock, we're going to have a decrease in cardiac output. The only type of shock that you would see a decrease in heart rate as well is neurogenic shock, okay, because again, you saw bradycardia. The other types of shock will also increase your heart rate. All of them increase your respiratory rate. All of them will decrease your blood pressure. So in terms of vital signs, they all look pretty similar, except neurogenic shock, you're going to see a decrease in heart rate. With hypovolemic and cardiogenic shock, your patient may be cold. There's going to be decreased perfusion and pulses. With septic, anaphylactic, and neurogenic shock, however, your patient will feel warm. They're going to have increased perfusion and increased pulses. These next few slides will show the different types of shock in an algorithmic form. And you see with hypovolemic shock, there is decreased intravascular volume leading to a decrease in output. Well, then our catecholamines are going to be released because we need to increase the SVR. We also are trying to increase the heart rate contractility as a compensatory mechanism. With decreased cardiac output, we're going to have a shift of this interstitial fluid moving to the cells and causing a change in volume of the vascular system. Aldosterone, ADH, is going to be released, and we might even see some splenic discharge. This hopefully is going to increase the volume as a response to the shock. We're trying to increase our cardiac output, but then when there's more volume loss, our cardiac output will be decreased. This will then lead to lower systemic and pulmonary pressures, decrease in tissue perfusion, and we go back to impaired cellular metabolism, which we saw earlier in the algorithm. Now, these compensatory mechanisms are finite, but if the initial fluid or blood loss is so great and continues, the compensation is going to fail, and this is why we will get into a situation of decreased tissue perfusion. The clinical manifestations, one more time, of hypovolemic shock include a high SVR. You're going to have pallor, cold extremities, increased thirst, oliguria, low systemic and pulmonary preloads, as well as a rapid heart rate, among other signs and symptoms. Cardiogenic shock is going to result from an inability of our heart to pump enough blood to the tissue and to our end organs. And it's a state of inadequate systemic tissue perfusion, despite having enough left ventricular filling pressure and intravascular volume. And it's caused by extensive myocardial damage, and it appears to be aggravated even further when we have systemic inflammatory responses. So the overall result is going to be hypotension with a metabolic acidosis, and often this is going to result in a fatal outcome. But we do have medical treatment and hypothermia to treat post-cardiac arrest states, and this has actually improved the outcomes of most cases. And most often hospital mortality because of cardiogenic shock has decreased now with this new type of hypothermic treatment. But there are some pathologic conditions that are going to reduce the contractility, causing pump failure, impaired diastolic filling, and cause obstruction, leading to cardiogenic shock, which we've talked about earlier. Now, as cardiac output decreases, there's going to be compensatory adaptive responses, like our RAS system, our neurohormonal and sympathetic nervous systems. And this is going to lead to fluid retention, systemic vasoconstriction, and tachycardia, because we're trying to compensate at this time. Well, we'll also see activation of inflammatory cytokines and activation of the complement system. And this plays an important role because it will allow our body to try to fight in the beginning using the natural methods. We're going to see an increase in contractility, heart rate, blood pressure, all being maintained while we're in this mild state of shock through vasoconstriction that's in response to the catecholamine releases from the adrenals. A vasoconstriction is then going to increase our vascular resistance. However, the increase in myocardial demand and consumption of oxygen and nutrients by the heart is still there. When we have a difference in myocardial demand, then this burden is going to continue failing, and the heart, which can't pump adequate volumes of blood, is going to be forced then to perfuse the tissue, but insufficiently. This is going to increase coronary tissue and cellular ischemia even further, leading to myocardial dysfunction, and then shock. With septic shock, this is really the endpoint of a continuum of progressive dysfunction of the body due to bacteremia. And the disease process begins with infection that enters the bloodstream, causing this bacteremia. Septic shock is commonly associated with SIRS, which is systemic inflammatory response syndrome, and sepsis that has to do with multi-organ dysfunction. If sepsis progresses in severity to a septic shock, we are going to have multi-organ failure eventually. Septic shock is the most common cause of caused by gram-negative bacteria, although gram-positive bacteria can also cause a septic shock as well, just to a lesser degree, as well as viruses and fungi. In the ICU setting, research actually shows that 6 most commonly identified infections had to do with pneumonia, bloodstream, intravascular catheters, intra-abdominal urosepsis, and surgical wounds. And some are actually nosocomial or hospital induced. And so those are the types of infectious disorders that could cause septic shock in the first place. So the triggering bacterium or molecule is going to cause a pro-inflammatory response that will then release leukocytes, macrophages, monocytes, and platelets. But we're also going to see now interleukin 1 being employed, tumor necrosis factor alpha, and nitric oxide, which is a vasoconstrictor. With SIRS, you're going to see fever, tachycardia, dyspnea, leukocytosis, as well as bacteremia leading to sepsis. When we are in this septic shock situation, we'll see vasodilation, hypotension, tissue inflammation, tissue hypoperfusion, and this is why your patients are feeling warm at this time. But eventually, they're going to start to feel cold during myocardial depression and worsening tissue hypoperfusion. All in all, this is going to result in multiple organ dysfunction. Anaphylactic shock, you can see that there's an antigen that's been introduced and you have the IgE pathway triggering complement, histamine, kinins, and prostaglandins. This will lead to peripheral vasodilation, increased capillary permeability, and we're seeing a constriction of the extravascular smooth muscles. So with anaphylactic shock, this is what's causing the bronchoconstriction, laryngospasm, and oftentimes GI cramping as well. So patients are going to present with shortness of breath and stomach pain. Well, the peripheral vasodilation will decrease the systemic vascular resistance relative to the hypovolemia, leading to lower cardiac output, lower tissue perfusion, and back to impaired cellular metabolism. When we have increased capillary permeability, then the fluid is moving out of the extravascular spaces into the cells, leading to edema, relative hypovolemia, again contributing to the further decrease in cardiac output, tissue perfusion, and back to impaired metabolism. And lastly, with neurogenic shock, sometimes it's also called vasogenic shock. This is when we have widespread and massive vasodilation from an imbalance of our parasympathetic and our sympathetic stimulation of vascular smooth muscle. And occasionally parasympathetic overstimulation or sympathetic understimulation will persist, causing vasodilation, low blood pressure for extended periods of time. This is what's leading to neurogenic shock. Sometimes this will create a relative hypovolemia. Now, blood volume doesn't change, but the amount of space containing the blood has increased. So this is why it's relative hypovolemia. So when this happens, our SVR will decrease drastically as a result of this vasodilation. And the pressure in the vessels is not going to be enough to drive oxygen and nutrients to the capillary membranes where they need to be. And so this delivery to the cells becomes impaired. This will lead to decreased tissue perfusion and again back to impaired cellular metabolism. Our last practice question here is about a client who has adequate intravascular volume but is experiencing decreased cardiac output in tissue hypoxia. What type of shock is occurring? Now, if you answered cardiogenic shock, you're correct. It's defined as decreased cardiac output and evidence of tissue hypoxia in the presence of adequate intravascular volume. And lastly, multiple organ dysfunction, or MODS. This is a progressive dysfunction where there's two or more organs that are failing in result of an inflammatory response to several illnesses or injuries like sepsis and septic shock. Other things though, like trauma, burns, and major surgery can also put someone into MODS as well. The manifestations that you'll see of your patients, you're going to see respiratory changes, hepatic, renal, GI, and myocardial changes, and even failure. Now, MODS was first recognized as a distinct clinical syndrome back in the 70s. And now that we have advances in resuscitation and support technologies, it has allowed many patients with multiple organ dysfunction to actually survive past these life-threatening periods. And today, MODS remains a leading cause of mortality, though, in surgical intensive care units, however. The mortality for individuals with MODS has increased progressively from 54% with 2 failing organ systems to 100% if they have 5 failing organ systems. Also worth noticing is that people at the greatest risk for developing MODS are those patients that are older and patients with significant tissue injury or a pre-existing disease process. There's this thing called SOFA, S-O-F-A. This is a system that can be used to stage sepsis, and it helps to stratify patients with disease based on their risks and adverse outcomes and the potential to response to therapy. So it can really track who is at higher risk for mortality. And lastly, here in a more algorithmic approach, we can look at multiple organ dysfunction syndrome, or MODS. Now, if there is some type of injury or sepsis or disease, it can lead to endothelial damage, which will result in also neuroendocrine responses and a release of inflammatory mediators like complement, coagulation, and the kinin systems. This leads to massive and systemic immune inflammatory responses that will cause our body to be in a state of hypermetabolism, requiring more oxygen, and it exhausts the fuel supply, and we will eventually lead to metabolic failure, contributing to acidosis or impaired cellular function. Additionally, the systemic immune and inflammatory response can lead to vasodilation and increase in our capillary permeability, and could put us in a state of microvascular thrombi. Eventually, there's going to be a maldistribution of systemic and organ blood flow that can insult and target those organs specifically, but also just generally tissue hypoperfusion is occurring. So now we have oxygen supply and demand imbalance. Well, this can lead to tissue hypoxia and acidosis. Well, as there's tissue hyperperfusion, we also see a decrease in cardiac function, and this pathway of acidosis will lead to myocardial depression that would further lead to cardiac function, tissue hyperperfusion, and back into this looped area. Eventually going to put our patient in a state of organ dysfunction and multiple organ dysfunction syndrome, or MODS. Remember that when there is a damaged endothelium, as a result, the platelets and thromboblastin will be initiated, causing coagulation to occur, and it can put our body in a state of DIC. Now, you're going to learn more about DIC in second semester, but as just an overview, DIC is disseminated intravascular coagulation, which means that your body is clotting and bleeding at the same time. Excessive platelets and thromboblastin and coagulation occurs first, but once that's been exhausted, we don't have anything else to cover. So therefore, we're going to lead into not having enough clotting factors and excessive bleeding.